welcome Injectables EDU. I'm so excited we have a guest today. This is Dianne Morrill, and she is a pharmacy consultant and knows so much. Like, we met her at a conference and we were so excited to share her knowledge with you guys that we were like, would you please do a webinar with us? So this is our first of two webinars with Dianne. So we're going to do this one about understanding compounding pharmacies and GLP-1s. And then we'll be doing a second one as well on innovative products from compounding that you can bring onto your practice to help your patients feel amazing and look amazing. So let's get started. I'm going to run through a couple slides and then I'll have Dianne introduce herself further. So this is your GLP-1 compounding guide for aesthetic practices, co-hosted with Nexus Health Solutions. And to keep lawyers happy, information provided is intended for general guidance and not to convey specific tax, medical, or legal advice. This is for educational purposes only and may not represent the views expressed of Injectables EDU or of Nexus as well. So we are just going to have a good old chit chat. So without further ado, Dianne, why don't you tell us a little bit about yourself?
Yeah, well, first of all, thanks so much for having me. Very excited to have an opportunity to partner with you guys and support all of the clinics and practitioners that you guys operate with.
Thank you.
We have a lot of really great information that we're going to share today. To get started, my background in this, really, I kind of got started in this because my husband was working for a compound pharmacy at the time. I was in a high-powered career I was the director of operations and customer experience for a BPO, a business process outsourcer. So I would go into these large brands and I would tell their executives how to do their business better. And at this time, my husband had gotten started with this compound pharmacy, and I thought it was an MLM, a multi-level marketing scheme. Honestly, when he first got started, I was like, "Babe, come on, we can do better."
Oops. Yeah, not good.
But it was honestly such a critical point in our future, that the fact that this came into our lives, because it has been such an incredible journey. So while I was, this director of operations and customer experience, I was rear-ended in a car accident and I ended up with 5 disc herniations. I went through 10 and a half months of physical therapy, chiropractic, whole nine, traditional treatment model. I did 3 rounds of cervical and lumbar epidurals, and they were telling me my only remaining options were radiofrequency ablation and surgery. I would have had to do both. And those futures, frankly, aren't pretty. I was 32 at the time, and I was just like, this can't be my future. Like, I cannot be looking at surgery every 10 years for the rest of my life. That's just not possible. I had a 3-year-old daughter at the time. I couldn't lift her. I couldn't, sit in a car for more than 30 minutes. I couldn't vacuum. I couldn't do dishes. It was absolutely debilitating and life altering. And so the pharmacy that my husband was working for, they were just getting their sterile license, and they launched with peptides. And so I've got a little bit of an eidetic memory. So my husband hands me off the literature. He's like, read through this, give me the highlights. So I started reading through one of the peptides, and it was called BPC 157. And I was looking at it and I was like, if it can do 1/10 of what it says it can do, I have to give this a shot. I don't really have many other options at this point. And so I was very fortunate to have a prescriber at the time who was willing to let me try it. And I got it, and in 6 days, my pain was reduced more than I could say with the epidurals.
Wow.
And then I continued it around 3 weeks. I probably saw about 80% relief. And then at 45 days, which is the protocol I followed, I had 100% relief about 95% of the time. I still have herniated discs. I still need to be cautious, but I got my entire quality of life back. So I was very fortunate to be in a position where I was able to leave my role in CX, and I joined the compound pharmacy doing, marketing. And that was where this entire journey was born. I am the patient that, all of you are treating and trying to help. And so I've walked that journey personally, and, it's a very personal journey to me. It's why I'm so passionate about this area, because I've had an opportunity to see the way that peptides and holistic alternatives can literally be life-changing for people. And so that's where all of that started. Because I do have such a quick assessment for things that kind of just stick. It has allowed me to really start putting pieces together as far as formulary development, which is where a lot of my role has kind of shifted, and clinical education and consulting. So that's where we have kind of gotten to today, where now we operate
Great.
with multiple pharmacies. We do consulting with them so that they can have the most effective formulations. They can be up to date on the most, regulatory compliance pieces. So there's just a lot that kind of goes into it. And it's an area that I have just really enjoyed being in.
That's awesome. Yeah, when you talk to Dianne more, and we spent hours going over like all the font of knowledge that she has about different compounds and formulations, as well as just a really encyclopedic knowledge of how compounding regulations work, and how to navigate it, especially in these really, ever changing. Every day is something new and different. And we know that Injectables EDU, we try so hard to be as compliant as we possibly can, even though it's just growing ever more challenging to do so. So we're always going to try and find the right path forward. And so that's what we want to talk about today. Let's talk about introduction to understanding GLP-1 compounding. So talk a little bit about, in brief, like what is a history of compounding pharmacies and what kind of compounding pharmacies are there in the United States today?
Yeah. So, the history of compounding has been around for basically ever. When you look at where it originated, you're really looking at holistic medicine. So, centuries and centuries ago, those were the people out gathering things and kind of mixing with their own like little muddles and, creating their own salves. Like that is the origination of compounding. It slowly kind of converted with, the petroleum based era where Rockefeller kind of came in and completely changed the dynamic of medicine. So
Hmm.
if you go back and you look at a lot of where this all kind of stems from and your current medical associations, your current compounding regulations, a lot of this started with the petroleum product derivatives. And so he basically saw this massive opportunity because, he was this oil tycoon to be able to leverage the leftover products in a capacity that would just make him billions and billions of dollars. So
I
he
had no
hired,
idea where this was going. That's fascinating.
oh, yeah, oh, just wait, it gets worse.
Oh, yeah.
Um, and so he hired somebody to go in front of Congress and basically say that all holistic medicine was a bunch of quackery, and that they needed to implement a regulatory standard for training and education, which is where the current medical college was born. And so basically, that is why allopathic medicine came about. And so that's where you see, we are trying to treat symptoms in a very separated font. So you're really looking at individual components rather than the system as a whole and how they all interact. So that's really your major difference between allopathic medicine and the holistic model.
Hmm.
Holistic model, you guys are really recognizing, okay, the body as a whole is this intimate system where everything interacts. And if you affect one thing, there's a downstream mechanism. And so you're really trying to get to that root cause rather than symptomatic treatment where you kind of introduce a solution for the symptom, but then you create this cascade of new symptoms that you now have to add additional
Right.
components to try and resolve. So, compounding as a whole has very holistic roots. It definitely has gotten more regulated, which is great. It's important because from a safety mechanism, that regulation, that compliance, that oversight perspective is critical to help influence patient outcomes, patient safety, efficacy, potency. There's some critical components in compounding that should absolutely not be overlooked. But there is also a factor here where there is definitely some overstepping, where there are regulatory bodies that are coming in and dictating, how you can treat your patient, what you can, treat your patient with, and they don't really have any substantive justification behind some of the things that they're implementing. So, with this new administration coming in, which I know is highly volatile topic, there are some exciting components that will be happening in the health realm, because there has been talk about completely wiping house with the FDA. They've made, tons of nominations
Ugh.
to replace some of the bad actors there,
Wow.
and really help influence the future of the holistic realm. So there are some
Mhm.
exciting things happening.
Sure.
Um, and ultimately, I think that's going to speak to, patient benefit long term. There are two major categories within compounding. You've got your 503A pharmacies, which are going to be your patient specific. That's where you have to have a patient. You have limitations as far as ordering, so you can't just order by the case for a patient, kind of a thing. There are also limitations as far as BUD, which is basically your expiration date within the compounding realm. Now, I do always like to add this caveat.
Well,
A
let's
lot
say
of
what
your
bud is best used by date so people understand what that is. Yeah.
Yes. So with Bud, that is unfortunately, honestly, kind of an arbitrarily
Mhm.
established deadline. A lot of that, is implemented with the intent of safety. The struggle with that is, there are tons of independent studies that actually show Bud and efficacy last years beyond what is
Mhm.
allowable. And so just to kind of put this in perspective, within the state of Florida, we used to have a maximum of a 6-month bud, regardless of testing. So if we have independent testing that shows efficacy, potency, sterility, stability, all of those pieces are maintained for a year, it doesn't matter. We can only put 6 months on it. And then now they are shortening that to 90 days. And there's talk about shortening that even further to 60 days. So all of these things that we've achieved 180 days, and these are multi-dose vials. So you're talking multiple punctures. This has all been evaluated in a very, kind of sterile setting. These are all specific pieces that we have to walk through as a compound pharmacy. And these are arbitrary dates that are being established. And I think there's a perception within the industry that this is really being done not from a patient safety perspective, but more so from a let's kind of drive the compound realm into the ground kind of a thing, so that we can really
Mhm.
capitalize on the commercially available equivalents and get that
Got it.
margin back.
Well, so
So,
just, I mean, compounding was, just to go back a little bit, compounding was developed in order to be an adjunct to what was commercially available that the pharmaceutical companies were offering, that you were going to be able to offer customized formulations specific to a patient because it's not commercially available in a dosage or in a method of administration that you can't get. Correct?
to a degree. So
Okay.
compounding was actually around before commercially available options.
Sure. Yes.
But yes, it has kind of transitioned into this realm where compounding is your patient specific exclusionary option for the commercially available equivalents. What that's going to do is, MIT did a study and they found that 80% of commercially available oral options contain one or more allergy causing excipients. So we're talking
Super.
gluten, dye, egg, dairy, lactose, all of these things that have inflammatory cascades. And, right now we're in this society where inflammation is at an all time high, and people are doing all kinds of gut tests and food sensitivity and like all of this allergy testing to figure out what is driving this inflammation. And they just can't figure it out. They're not looking at their medications. And so what a
Mm-mm.
lot of people don't realize is some of these allergy, reactions that they're having, it's actually to the medication that they're taking every single
Wow.
day, and they're never going to get in front of it because they haven't figured that out.
Crazy. Okay, so then you have 503A, typically patient specific. 503B is, I always think B, bulk, and that is where you can order in bulk. But really, what's the difference between the actual how these medications are? Is there any difference in how the medications are made for in either one of these pharmacies?
Not necessarily. Now, the partner that you choose is definitely critical. Not all
Yeah.
compound pharmacies are created equal. And when you look at regulatory oversight, FDA is the one that oversees 503B. Now, they still help to provide the regulatory components for 503As, but the primary factor for your 503A regulatory is going to be your state boards of pharmacies. Those are the
Mm.
ones responsible for coming in, inspecting the facility, making sure that their operations are, um, quality. And so, you really when you look at the state regulations, unfortunately, to a large degree, they are subpar to really ensure safety, efficacy, potency, some of those really critical pieces. And so, really, where you want to make sure that you're selecting the right partner is you want to look at accreditations above and
Mm.
beyond. We're USP 797 or 795 compliant. That is the bare minimum that you are looking at. You also have to go in there and say, okay, do you have a PCAB accreditation? Are you NABP accredited? Those are kind of your gold standards. And what is happening there is they are literally paying an outside entity to come in to their facility and say what they're doing wrong so that they can improve,
Hmm.
because you don't get that with the board of pharmacy. Granted, they will recognize glaring errors. They are not there to help you by any degree, and they try to find as many errors as possible so that they look like they're doing their job, which is great. That's great. Identify all the issues. The struggle is they only come once a year. They again are bare minimum, so it's like, great, you can be a C student or you can be an A student. Which one do you want to
Right.
do business with, kind of a thing. And for me, I've always looked at the A student. And let me give you a great example of this.
Okay.
Right now, there is a compound pharmacy, and I'm not going to name them. If you do a little bit of research, you can kind of figure this out pretty easily. But they are a 503A pharmacy. They have been shipping nationwide, and they have had crazy cheap semaglutide and tirzepatide. And this is always a big red flag in this
Right.
industry. If it's cheap,
Really, really cheap. Yeah.
yeah, if it's cheap, it is not quality, because those two things do not come into the same realm in compounding. And so, you have to really look at that. And so, what's happened is the Department of Health has now filed a complaint against this compound pharmacy, because not only are they not licensed nationwide for shipping or dispensing, they're licensed in 2 states for non-sterile. They don't even have a sterile license.
Ooh.
So, and this compound pharmacy was dispensing to a significant degree nationwide to some really big clinics, one of which is a massive telehealth clinic, who
Mm.
now has a Facebook group called the Refund and Chargeback for this telehealth clinic, which is
Ooh.
amassing thousands of patients who want refunds. So here's your big watch out here. There's this kind of misnomer in the industry that your responsibility, your culpability as a clinician is kind of out of that realm because it's the
Hmm.
compound pharmacy. Risk, liability, culpability, all of it falls on the compound pharmacy because they're the ones producing and dispensing the medication. Here's the struggle with that. If you are the clinician who is collecting payment from the patient and submitting it to your preferred pharmacy, you have a responsibility to do the due diligence necessary to ensure that you are working with an appropriately licensed vendor who will supply a
Yeah.
quality product and not put your patients at risk. And so, I was having a conversation with another clinician who's like, well, I don't really see how the clinic is going to be responsible for that. And then we walked through these pieces of
Hmm.
exactly what I just shared. And he's like, oh,
Oh, yes,
yeah.
exactly.
So, there is, and beyond that, this isn't just, oh, you might have to refund thousands of patients. You're now looking at potential bankruptcy, so loss of your business. What about medical license censure, if not complete removal? And at this point, there may be a criminal aspect because of the gross negligence here. So there are some very big pieces that if you get in with the wrong supplier, it can go wrong real fast
It's so
and in a
hard
big way.
having had a lot of conversations with different pharmacies because they say, "Oh yeah, we can ship to that state." And then you're like, "Well, send me that documentation." And you're like, "Well, we don't have this," or they'll send you some piece of paper and you don't know what you're looking at. I mean, we're nurses. Like, I don't know how to vet these things. And there's no board per se. Like, so unless it's a national certification board, if you're looking at the smaller pharmacy, there's often no place to look, like really look. So, I think we go back to the two accrediting bodies. Can you say those slower? What are the acronyms for them?
Yep, it's PCAB, which is PCAB,
Okay.
and then the other one is NABP,
Okay.
and
And
those
so
are
if
both
people
kind
ask
of.
for those, you feel pretty confident that this is a reputable, you can work with them and feel safe.
Yes, those are kind of your gold standards as far as quality and efficacy. Now, there are still some licensing components that can come into play above and beyond that, because you want
Sure.
to make sure they're licensed for sterile and non-sterile dispensing within your state. Now obviously, I think the big piece here with this compound pharmacy is that they didn't have a sterile license at all.
Mhm.
So there's a big issue there, because if you're not even licensed in sterile, there are a lot of critical components that go into sterile production that if you don't
Sure.
even have the license, you haven't gone through the classwork, you don't know what you're doing. There's a
That's
lot of risk
scary.
that comes with that.
Yeah.
Yeah.
Ugh.
So, working with somebody who has at least a sterile license in multiple states, and because there's lots of clinics that are outside states, that like California, nobody can get a sterile license there. It's just impossible. So, there's a lot of clinics that will kind of route things through other states. So there is an increased risk there. If something goes wrong, they're now dispensing, medication in a state that the pharmacy didn't have a license in. But as long as you're working with a quality pharmacy, the risk there, as far as the patient seeing an adverse reaction or deficit there, is pretty nil. But you do want to make sure they're at least licensed to a sterile degree, and if they've got an accreditation, then that is a really important key critical piece.
And is that like a document that a compounding pharmacy can produce and send to you?
Oh
Or
yeah.
yeah,
Yep,
okay.
and you can even go online and look it up. I'll send you the link where they can go
Great.
search it afterwards, because that's a key piece as you guys kind of move into this, because there's a lot of change happening in the industry right now.
A lot. Well, let's talk about that because it keeps coming up as, things are coming on and off FDA shortage, where I guess read the tea leaves. What do you think's happening with Sema and Ters?
So, semen and tirzepatide, here's what's happened historically. So, both of those have been on what's called the FDA shortage list. And essentially, what that list provides is an opportunity for compound pharmacies to produce medication that is under patent and commercially available. And essentially, when they come onto that shortage list, the FDA no longer considers them commercially available, which is why compound pharmacies can kind of actually start producing it. What they're doing is they're helping to bridge the gap between supply and demand that is currently occurring for the commercially available equivalent. Um, the struggle with what's happening right now is, you know, um, basically the commercially available equivalents are saying that they have an adequate supply, and that there is no reason for compounding to be able to continue. Now, there's several issues with this. One, as a compound pharmacy, we can't even get the commercially available equivalent. So it's like, if it's available, why can't we get it? And so
Mm-hmm.
just because you list it as available doesn't mean there's actually access restored. So there's a very big difference there. And I think that's part of the lawsuit that is ongoing with the FDA, with a couple of pharmacies that have filed suit against them over this entire issue. And it's basically saying, you're saying that supply has been remedied, but there is no access. So
Right.
how is that a remedy? And so they are holding the FDA accountable in that respect. And the FDA is starting to back down a little bit. They have basically said, at this point, they deem the supply adequate. However, in light of the ongoing lawsuit, they will continue to allow compounding pharmacies until it's been resolved. Now, the commercially available equivalent has asked to join that lawsuit because they do not feel the FDA will adequately represent their interests. Um,
Mm-hmm.
and I think here's your big watch out for the future. Um, the FDA has basically come out. There's some critical pieces that will allow continued compounding of tirzepatide and semaglutide. And basically, what it comes down to is um, a couple of things. The FDA has said that you can produce a commercially available equivalent as long as it is not an exact copy. And what qualifies it as not being an exact copy is it has to include a patient specific change that provides a significant clinical difference as determined by the prescriber. So there's three big pieces of information within that statement. Um, You're looking at customized schedules. So if the commercially available equivalent cannot accommodate the dosing schedule that you as a prescriber deem to be relevant for the patient, and when you look at the commercially available options, they are pre-drawn syringes or single dose vials, which means you really have limitations as far as the use case scenarios for those. You are beholden to the protocol that they have established as far as that titration mechanism, which there's some big jumps in there. I think it goes from like, I think there's like over a milligram dosing titration at one point within the standard protocol for semaglutide.
Right.
And like, most patients don't need that.
No.
You can titrate at 0.5 milligrams and really extend that runway for weight loss, mitigate the side effect profile, improve tolerance and compliance. So there's some key pieces here that really help improve that patient benefit, and do offer that significant clinical difference as defined
Yes.
by the FDA. Beyond that, there are also things that you can do to combine with the active ingredient, so the semaglutide or the tirzepatide. And those look like L-carnitine. Muscle wasting is a big concern right now.
Hmm.
And I will tell you, it's not necessarily specific to the GLP-1. You will see muscle wasting in that Ozempic face,
Right.
um, in any kind of rapid weight loss. Go look at gastric bypass outcomes. You see that exact same outcome where you've got that muscle wasting, you've got that Ozempic face of sorts.
Hmm.
You're just losing the volume because of the rapidity of the weight loss. So L-carnitine is great for muscle preservation. You kind of have that as the argument. You've got a lot of compound pharmacies that are combining it with B12, which is critical because there are clinical studies that show GLP-1 use comes alongside a B12 serum depletion. So
Yep.
you can help combat that. Now, there are some caveats to that. A lot of these compound pharmacies are using cyanocobalamin as the active B12 component. Here's your nuances with that. And this is where, not necessarily that you'll get in trouble, but at some point, this may become a supply disruption. Cyanocobalamin is commercially available. The FDA has said that combining two commercially available equivalents does
Oh,
not
funny.
create a new
Hmm.
medication. If you are supplying both of those products in one medication, they have to use the independent commercially available products. So you have to independently dispense semaglutide
Got
and
it.
independently dispense B12. Now, the only one that is not commercially available is methylcobalamin. It is, however, the least stable form of B12, which is why most compound pharmacies leverage cyanocobalamin. Now, presently, with the bud studies being limited to 90 days, methylcobalamin is sustainable for at least 90 days. A majority of patients are doing it through their vial that they order within 90 days. So that's less of a concern. It is also the most bioavailable option. So all of the other versions of B12, cyanocobalamin and hydroxycobalamin, they both have to be converted into a usable form by the body. And
Mm,
right now, 50 to 80% of the patient
that's
population
crazy.
is being diagnosed with the MTHFR gene mutation, which means they cannot convert cyanocobalamin and hydroxycobalamin into a usable form. So
Hmm.
methylcobalamin is kind of your premium option as far as B12. I have not found a pharmacy that is actually using that as their active in combination with semaglutide or tirzepatide, though. So that's going to be a challenge there. And then another one that's really good is B6. So nausea and GI upset is a very
Hmm.
common complaint with your GLP-1s. And so B6 is kind of your more natural version of anti-nausea options. So finding a combo with B6 is great. And so those are kind of your three pieces that you can leverage, and you have to document this on the prescription of why you are justifying that the patient will see significant clinical difference. And so make sure that you're using kind of those arguments as you're ordering from your pharmacies.
And do you encourage people to also document, like in their chart notes, like using this formulation to mitigate these effects?
Yes, absolutely. Having it documented within your chart notes, and on the prescription itself are going to be your two critical key pieces to cover your butt in the event that you get any kind of regulatory oversight or involvement. So that way you just are really covering your bases. Now, the FDA has also said that they are not in a position to basically question whether a prescriber has done whether the significant difference to the patient is valid or not.
Oh,
So ultimately, they are leaving it up to the prescriber to determine the validity of the significant difference, and they are not in a position to question it. So just make sure you're documenting on your end, and that should
and that should
satisfy
be doing. Wow,
the
that's going to make
the
people feel
requirement.
a lot better.
Yeah.
Super. Okay. Well, as we come to a close on this section, talk a little bit about you work and recommend a couple specific pharmacies. So if people wanted to work through pharmacies that you have vetted that you feel really good about, who would that be and how do they get accounts?
Yeah, so we operate with a couple of different pharmacies. In conjunction with you guys, we have actually created a buyer's group of sorts. And
Hmm.
really, the way that we have to position this from a legal perspective is we are the payment intermediary. And what that is allowing us to do is, because I've been in this industry for so long and worked with some really large clinics, I know the absolute bottom rate that these pharmacies will accept for the quality products.
Quality
Um,
product. You can get it
yeah.
less, but it's just like anything else. Like cheaper isn't better, guys, and protect your license. So a little bit of extra expense for that great experience for you and for your patients is well worth it.
Oh, yeah, absolutely. And so that is now called the Clinician Advantage Group. And
Yay!
yeah, so exciting things. And
Hmm.
not only have we negotiated bottom rates on GLP-1s, we have worked through that for BHRT and IV micronutrients and anti-aging cosmeceuticals. And
Yay!
we're going to continue kind of adding to that lineup for you guys. And we're basically leveraging our negotiating power collectively, so that we can achieve those bottom rates that these really large clinics are already able to get because they've
Right.
got the volume to justify it. And so this is allowing us to put all of you in a position where you can now compete with them.
It's awesome. We're grateful. Thank you for your work. And what pharmacy are we you recommending that we order through that have all these things?
Primarily First Choice Pharmacy.
Yep.
So, when you reach out to us, we'll get your account set up form, we'll get your service agreement, and then we'll get you set up with the pharmacy. We will also facilitate all of your day-to-day, needs as far as, orders that are placed with the pharmacy. Now, they are still responsible for dispensing. You are still responsible for prescribing, but
Yep.
we are so ingrained in this business. We know, turnaround times, we know ETAs, we know products, we know pricing, we know billing, we know all of the things. So we're here to really help alleviate some of those pain points that you commonly see with compound pharmacies.
Yay, I'm so excited. We are very excited about this. So, cool. Well, I think that puts a bow on our first half. And so we'll put a pin on this and feel free to reach out to Injectables EDU if you would like to sign up, if you have follow-up questions. And thank you so much, Diane. Appreciate your time and explaining all this good stuff to us.
You're very welcome.
Take care.